Hey everyone, I am Dr. Natesh, and today's episode we're going to have Dr.Annamaria, the President of International Society for Sexual Medicine. Welcome, madam.
Thank you. Thank you for having me here.
Thanks a lot. And this is your second Indian visit after the SASSM conference. You come for this Diabetic India Congress in Bengaluru. How do you see India? How do you like India?
I like India very much, and that's also why I've come back.
Okay.
People are very, very nice and friendly, and there's a lot of interest in sexual medicine.
Yeah.
I have the feeling that a lot of things are going on in the field of sexual medicine.
Good. So, you being a psychiatrist, basically, trained psychiatrist, and you being a clinical pharmacologist, me being a pharmacologist, so it excites me to have you on the show. So, how do you see your journey from a psychiatrist perspective to a sexologist perspective?
My personal journey was that I wanted to be a urologist when I was a young doctor. So I was involved in the area of the Viagra when it came on the market. And then it turned that most treatment of sexual problems in males, instead of being surgical, became pharmacological.
Yeah.
So I moved with that, and I was involved in some of the first clinical trials of the PD5 inhibitors, and that was very interesting. There was a lot about pharmacology. So I thought, pharmacology is really a nice area. And then we started working with pharmacological treatment of women's sexual problems.
Okay.
And I realized that when it comes to women especially, but also with men, it's very nice also to talk about the psychological aspects of sexual health. And I realized that maybe psychiatry is the best way to do that, because there you can integrate pharmacology and psychology and psychiatric approaches.
Okay.
So it was a journey from wanting to being a surgeon to ending up being a psychiatrist. And also where I come from, there's a tradition that sexology is practiced a lot in psychiatry. So the department we have, the biggest sexological department we have in Denmark is in psychiatry. So it made sense.
Okay. So you just mentioned that there was a shift from the surgical standpoint to the pharmacological standpoint from Viagra trial. Can you give me a weakness from that, if you can remember? How was that shift?
The shift was very dramatic because it meant that before, if you had erectile dysfunction, you would either go to a psychiatrist who would do more psychoanalysis and psychiatric therapy, or you would go to the surgeon that would try to re-establish your blood vessels to the penis or have injections into the penis. But by having pharmacological treatment, it was something that the GP could do and endocrinologists could treat, and you would find out that you could treat many more men in a much better way. So it really changed the treatment of sexual problems in men at that time.
You were involved in a Cialis trial also?
Yeah.
So how was it different from the Viagra trial?
I think it's basically the same mechanism. So the small differences are interesting when you're a pharmacologist, because they have to do with how long do they work and can you take them daily, or so there are these small differences that are actually based on the pharmacological characteristics of the drugs, but I think basically they work in the same way.
Because Cialis was introduced as on-demand dosage.
Yeah.
And now people are having a daily dosages.
Yeah, I think that's the big difference. That Cialis you can have on a daily dosage, and that helps a lot of men, especially younger men that want to be more sexually active and don't want to plan so much when they're going to have sex.
Yeah. So when talking about younger men, in India there is a big stigma.
Yeah.
When there is an ED, people don't come out very often. They go to multiple persons who are not even specialized. I don't want to call them quacks or something like that. They go, they burn out all the money, and when they come to us, they tell doctor, give me a cure immediately. And even India being the land of Kama Sutra.
Yeah.
And this is a very, very sad thing happening to us. How are Danish people's perception when it comes to sexuality and the sexual problems?
I think that Denmark is a little bit different from India because we have less religious society, we have less traditional society, and we have a society where the liberation of women have been promoted for quite a long time. So there's a lot of focus on how important it is that the sexual life is working. And there's a lot of focus on sexual life not being only to have children, but also because it's fun and it's nice.
Okay.
So we don't have a lot of restrictions of sexual life. You know, people are allowed to have sex before getting married, and so it's a little bit liberal. But having said that, I think it's always difficult to talk about sex. And what you describe about men, we also see in Denmark that it's very shameful for a man to have erectile dysfunction, especially if he's younger. You know, he will have all his friends bragging about how good they are and how many times they have sex. And then they feel very embarrassed, and very often when I see them in the clinic, they have done what you say. They go on the internet, they buy drugs on the internet, and they end up in the clinic, and I feel it's so embarrassing to talk about, and it's actually the first time they talk to someone. So I think that even though you could say we have a very liberal approach towards sex in Denmark, it's still difficult to talk about. And I think it's because sex is something that's very personal, and you have a lot of expectations to how it should be.
It makes me to think about people have the more freedom to express their sexuality, but not their sexual problems. So that is still there, even in your country. People are very open about being a gay, being a lesbian, but they're not open about having a problem, which can undermine, which can tell about their own body diseases, diabetes or hypertension, something like that.
I think you're right, because everyone expects sex to be something that just is there and that works. So when it doesn't work, people feel very shameful. And I think also in Denmark, it's very difficult for the physicians, for the doctors to ask about it. So they don't mind asking about how's your diabetes, how's your stomach, how's your urine. But the doctors have a taboo in asking about sexual health. And when they have it, the patients will feel, okay, this is something we don't talk about. So that's a problem we have in Denmark too.
Okay. So now coming about the problems very specific to women, how much people are aware of that? Because when talk about sex, people consider men performing and women receiving. So how women problems are different? How can we address this?
I think that if we look at women with sexual problem, the main problem is lack of desire. And if you don't have desire, it becomes a little bit difficult to have sex, because then you won't have arousal, and then you might have pain, and then you might have orgasmic problems.
Is the desire an organic issue or a brain issue?
I think it's. I think the brain is also organic, but I think that it's something what we would call psychological. So very often it is because of psychological processes. Maybe they're too tired. Maybe they are feeling that there's too much they have to do. Maybe they don't think they get the right stimulation. And also we need to recognize there are differences in hormones, that women have less testosterone than men. So I think that they don't have the same drive. So they need what we would call motivation. So they need a motivation to have sexual desire, and that's where the relationship is very important. If they have a nice relationship, if they feel supported by the partner. So this is what you would call the brain or more psychological aspects.
So what I perceive is that when there is lack of desire in women, it has a lot to do with the men. Because men just pound on women, they just go have desire, they just tell that, okay, I'm aroused now, then you should be aroused. So that is a big difficulty which we can address even in India, I don't know about Denmark. I think it is same.
I think it's a pattern like that is always problematic, because at least in my practice I see that a lot of women will feel, oh, this is just another obligation I have to do. And so we have to focus in treatment on how do we have foreplay, how do we make sure that the woman also is motivated, and not just the man coming and say, now I'm aroused and then I want to have sex. So you need to have some interaction, you need to have some intimacy. In Denmark we have a lot of people that are working quite a lot. I guess it's the same in India. So people, they will come home from work very late, being very tired, and then they expect that now we should be in the mood for sex, but they're not, because they have not been in contact with each other the whole day. They haven't been kissing, they haven't been talking, so they don't have any intimacy. And then it's very difficult just to jump into the bed and then feel desire.
They just think about sex when they have some contact on the bed.
Yeah.
The whole day their mind is completely with the earning money, with the kids, and they think like it's like a magic, just go onto the bed, just have sex.
Yeah.
So,
and I think it's a challenge for us as healthcare providers that we need to explain people that sex is not just something that just happens when you are in a relationship. I think when you're young and in love, it happens all the time. But when you get into normal routine and normal life, you need to work on it, you need to have some time, you need to not be too tired, because the body is trying to protect itself if you're very tired or stressed, and then it closes down desire. And I think it does it more easily in women. It happens in men too, but I think in women they're more vulnerable to these changes.
Any specific reason for the women being shut down very early?
I think it's also because they don't have that much testosterone, so they don't have like the hormonal drive. They need more motivation from something else.
So can we have a cutoff range for women testosterone? Because we measure men's testosterone.
Yeah.
So do we have any cutoff for women testosterone?
No. The thing is that we know that women are influenced by testosterone, but we don't know what the level should be like we do in men. But we also know that some postmenopausal women will benefit from treatment with testosterone if they don't have desire. But still, it's an area that needs to be explored more, because we don't have a cutoff saying this is the level. And I think we should be cautious about treating with a hormone if maybe it's more lack of stimulation and a bad relationship that's the reason for having a problem.
Because more often, it's very easy for us to measure the estradiol concept. And they give like estrogen cream or the ointment. Nobody's going to measure the testosterone, because you told testosterone gives them a good drive. I think there should be more amount of study to have a large cohort where they can have a testosterone cutoff for women also. And we can have a testosterone boosting therapy for women. But it's a double-edged sword. Where they can lose their own feminism. So we tried to do a study like that, and we couldn't find a cutoff. You couldn't find it?
No. We can see that testosterone is related to desire, but also we found that if the women were depressed, then they had sexual problems, and if they had a bad relationship or the partner had a sexual problem, then the woman would also have a sexual problem. So there's so many other factors than testosterone, so you need to try to find out what is the most important one.
So, talking about female sexual problem, this is just for the audience. What are the types of FSDs, female sexual disorders? A broad classification, maybe a basic thing, but still our audience would like to hear that.
So we have different types of sexual problems in women. One is what we call hypoactive sexual desire disorder, meaning that the woman doesn't have desire for sex. And the way it's defined now is that it's that you don't think about sex, you're not motivated for it, and you don't have receptivity, you don't react in sexual stimuli. And you need to be distressed about it, because some women will not have desire from sex and they're not distressed. And then you say it's not really a dysfunction, but still it can be a problem in a relationship. So that's the low desire problem.
Can we tag this as a disorder? It's a lifestyle factor, no? But people call it like as a disorder.
I'm sorry, I didn't know.
I believe that this is a lifestyle factor. The low desire. Can we tag it as a disorder?
I think
because
you can.
Because from the a past perspective, people have tagged gay and lesbian as disorder, psychiatrists, and now they removed it from the DSM.
I think we can do it, but I think we need to be critical about what is normal, that we shouldn't call something a disorder if it's within a normal range, and if the woman is not distressed about it, then we shouldn't call it a disorder. I agree with you. Then we have arousal disorders, which mean that you have difficulties in becoming aroused in the body, especially in the genitals, meaning that you will not lubricate, the woman will not lubricate, she will be dry. And that is something that we see especially in postmenopausal women after they don't have estrogens anymore, but also if the women are not stimulated the right way, premenopausal women, if they don't receive enough stimulation, then the body will not react well enough to lubricate, or if they are very afraid about what's going to happen, or they don't feel comfortable. So that's the arousal problem.
So is there any difference between stimulating a premenopausal woman and a postmenopausal woman? Is there any difference?
I think that
should we teach men separately, because men can present with ED if the woman is having, because here like it is a very one-with-one partnership.
Yeah.
So if the postmenopausal lady is not lubricating properly, men comes and tell me, sir, I'm not having any desire to have sex.
No.
So then I inquire, how is your wife? She's equally non-desirous.
Yeah.
Then if she is not having proper sex stimuli, the men loses the same.
Yeah.
So how should we address this issue in both men and women?
I think it's always good to educate both men and women. I think it's good to educate about how the genitals work.
Okay.
And I think it's good to educate men about women need stimulation to become aroused. Mm-hmm. So if the man just presents with an erection and say, now I want to have sex, and she hasn't been stimulated, she's not going to be aroused, and then it's going to hurt.
Okay.
So it's a good idea to teach about how the genitals, where's the clitoris,
okay,
how do you stimulate. And we know from studies that postmenopausal women can lubricate,
okay,
but maybe they need more stimulation.
Okay.
So sometimes what happens with older couples is that she needs more stimulation because she's postmenopausal, and maybe his erections are a little bit weaker because he's getting old.
Okay.
And then she's a little bit dry, he has a weaker erection, and then it becomes very difficult.
Okay.
So we need to recognize that both men and women need more stimulation when they get older. Men do that too.
Okay.
So if you just continue doing what you always did, that might not be good enough.
Okay.
So I think what you're saying about educating is very, very important to talk about, also touching the rest of the body, not only the genitals.
But what happens when we address them, they tend to have an experience, they tend to feel like they are more experienced.
Yeah.
And they deny the concept of teaching them.
Yeah.
How would you address that issue?
I think that's what you're doing now. You need to educate people. You need to educate healthcare people. You need to educate nurses that maybe can talk to patients. You need to, if possible, educate people in the school, in the older classes when they start being sexually active. But it can take a long time.
It will take a long time.
Yeah.
Okay. So we spoke about this FSD, hypoactive disorder.
Yeah.
Arousal.
Then you can have orgasmic disorder, meaning that it's very difficult to get an orgasm or it's impossible. And a lot of women will not experience orgasm. And you need to find out what is the problem, because most women, younger women, are able to have an orgasm, but they need to know how to do it, and they need the right stimulation. And for some women, it's not intercourse, maybe it's other types of sex, or it's manual stimulation.
Non-penetrative sex,
So we know from experience that if the women are allowed to masturbate and stimulate themselves, they learn how to do it, and then it's easier. And then it's not only the responsibility of the man, I think it's also the responsibility of the woman, that they learn how to do it.
Here it's a big taboo, because even masturbating in man is considered a sin, and women is absolute no. So when we ask about that, they tend to get offended. So we have to overcome that. So if the woman is not able to perceive orgasm, so only way to teach them is to proper masturbation for them.
And I think you can also teach the couple to stimulate each other. And that could help if a man has premature ejaculation. It might also help him in, doing something different, that the woman stimulates him in another way. So I think that's always good to tell about. You don't just get an orgasm by having intercourse. You might do something different. So
we spoke about this sexual arousal disorder, and what about this? Like, you have been a committee member of hypoactive sexual desire disorder in women. Do you have any drugs very specific for that to treat it, or only counseling or education is there for them?
Yeah, I think basically there are two ways of treating sexual problems: with drugs or with therapy, and sometimes we combine it. And we know that we have quite a lot of drugs for men, and we have fewer drugs for women. And I think there are some reasons for that. One reason is that the drugs we have for men mainly are hormones, and then we have the PD5 inhibitors treating erection. But women, most of the time, have problems with desire.
Okay.
And it's a little bit difficult to treat desire because it's something that happens in the brain.
Central component is there.
It's a central mechanism.
Yeah.
And so we have some new drugs that have been approved in the United States.
Okay.
There's a drug called flibanserin, which is a drug that acts on the serotonergic, dopaminergic, norepinephrine system, and it increases desire. So it changes the balance in the chemistry in the brain. It's for premenopausal women. We have another one called bremelanotide that's also approved in the United States, also for premenopausal women.
Okay.
And that's also increasing desire and arousal.
Okay.
And then we have testosterone, as we discussed before, for postmenopausal women. And that's the drugs we have. So a lot of the things you can do with women is more in the sexological sex therapy area, where you try to increase intimacy, talk to the couple about how do we communicate about sex, teach them to do other things that they usually do. But you can combine it.
Combine that, fine. And you have done more about this genital sexual pain.
Yeah.
It is not about genital pain syndrome. It's a different thing. So can you enlighten me on that?
Sexual pain is quite a problem for many couples. It's especially, there are many reasons why you have pain when you have sex when you're a woman. Some of them are very obvious, that if you have an infection or you have a dermatological condition, or if you have something that's destroying the tissue or giving you an infection in the tissue. But we also have a lot of women that have pain when they have sex without any obvious reason. And a lot of them are women that are very anxious about having sex because maybe the first time wasn't very nice. So they are like very anxious, so they contract their pelvic floor, and they do not lubricate because they're so anxious, and then it starts hurting because they don't lubricate. They have a very tight pelvic floor, and sometimes they get what we call vaginismus, where you contract your pelvic floor so much that you cannot penetrate. And the way we usually work with that is the more psychological way, because it's like a phobic reaction. It's like they're so tied up, they're so afraid that they cannot enjoy what's happening. So they start thinking about what is going to happen, and this is going to hurt, and then they have this downward spiral where they cannot lubricate. Then it hurts even more, and then everything is bad.
Keeps on going again
and again. And they keep having sex because they want to have, they might have desire, and the partner wants to have sex. And then it hurts again, and then the tissue becomes more vulnerable. So it's really a bad spiral. So it's a challenge sometimes to treat it.
So, and when talking about sexual well-being in women, we never address the sexual feelings of women attending the fertility clinics when they come for IVF. So, like, any tips on that, like for the gynecologist?
I think that
address that.
Yeah, I think that both men and women in fertility treatment have a risk of having a very complicated sexual life. Because when you want to conceive, everything becomes about when to do it. And it has nothing to do with desire. And we have seen a lot of both men and women that feel that sex becomes very mechanical. You know, the wife will call saying, now you need to be home because now we have to have sex. And that makes it something that is very mechanic and not very pleasurable, not about having desire or wanting to have sex. So I think it's very important to discuss with people that this might happen, and maybe also ask them to have some intimacy without thinking of conceiving and just focusing on feeling nice together. And I think also that it's a burden to be in a fertility treatment. So if you don't become pregnant, you become very sad, and then we have to go all over again. So it's a very stressful period. And we know stress is also bad for the sexual life.
Many gynecologists, they don't address this issue at all. They only focus on IVF or success.
I think it's
this needs to be addressed both for men and women.
I think also for the men, because quite a lot of men will say, I feel like, I just need to have an erection and we need to have sex now. It's very mechanical. So I think it will help just to talk about it, and then people can calm down and know, okay, this is a natural part of it.
And you have mentioned in your article about the sexual well-being, post-endometriosis resection. Post-endometriosis resection, sexual well-being in young women.
Aging women?
Young women. Sexual well-being, post-endometriosis. So, I don't see many gynecologists even address this issue.
No.
They just resect the endometriosis tissue. And if the pain is gone, then they are cured. Nobody addresses the post-sexual life after that.
No.
So any tips for them how to address that issue?
I think that my overall tip is that start talking to your patients about sexual life, because we know that women with endometriosis have more sexual problems because they're used to sex being something that can be painful, and that's put a psychological warning in your body. So I think that the tips are that talk to the women and the men about sexual life, and that's the best way to help them.
Do you have many, they come with their own parents, and they won't even open up?
No.
And the treating doctors, they don't open up?
No.
I think they should be having a very private session with them.
Yeah, I agree.
Specific for that.
Yeah, I think it's difficult to talk about sex if your parents are there. I mean, no one likes that.
Yeah, true. That's absolutely true. And being in a diabetic conference today, so tell a few things about how to assess sexual dysfunction in a diabetic woman in a busy diabetic clinic. Because many diabetologists are men.
Yeah.
Equally, women also are there. But still, when we get a patient, how to initiate a conversation?
I think that we know that women with diabetes are an increased risk of having sexual problems because they have the complications, so they have less arousal, they might have orgasm problems, and they might have more infections, and also they have less desire. So we need to recognize that, and we know that women with diabetes are more depressed, and depression is a risk factor for having low desire. So the way I would do it is that if I have a woman with diabetes, I would say, I as a doctor know that sometimes you have problems with your sexual life when you have diabetes. Is that something you experience?
Okay.
So if the woman doesn't experience it, she can say no, or she can say, I don't want to talk about it, or she can say, I'm very glad you asked me, and I would like to talk about it. So if you have an open question, making it a little bit general, so it's not like this specific woman, but saying, I know someone with diabetes have a problem. And you could do the same with men.
Because what I do is that I push the IEF questionnaire or SIM scoring. Because in the clinic, very specific to diabetic, they'll be coming with the couple or the father or the kid. So I just strip it off. Is there any very particular questionnaire, because you have written a review on the variation in the sexual dysfunction questionnaire, is there any one single questionnaire, short questionnaire, where you can push through women?
We developed a few years ago a screener with about 10 questions that said, do you have problems with desire? Are you distressed about it? Do you have problems with pain? Are you distressed? And do you want to talk to your doctor about it? So that's a very small, easy one where you can see, okay, the woman says, I have a problem here and I would like to talk to someone. That doesn't give you a cutoff that says she has a dysfunction or not, but it gives you an indication.
We can address this issue. At least we can do that.
And it gives you an indication where's the problem and should we talk about it.
What is the questionnaire for the audience?
It's called a sexual screener for women.
That's it?
Yeah.
Not specific for diabetic women?
It's a specific, it's just for women.
Okay.
And we have the same one for men actually.
SIM scoring? Or different one?
No, it's similar.
Okay.
So it's about male problems.
So sexual screener for women and for men?
Yeah, sexual screener.
No, OPD setup they can use it?
Yeah.
Okay, very good. So any major shifts in the understanding of the women's sexual disorder which you have seen in your past practice?
I think that one of the major shifts are that we think now that women's sexuality is more important. Because when we had the treatment for erectile dysfunction with men, we realized that if men are going to have sex, they have it most of the time with women. So we need to help women too. So I think one of the shifts is that there's more focus on that women should have pleasurable sexuality too.
Okay.
And then there's the shift that there are introduced pharmacological treatment, but a new shift is also that things like mindfulness has been introduced in the treatment of sexual problems, because mindfulness is a type of therapy where you use an old technique about just being present in the moment.
Okay.
And we know that a lot of women, when they have sexual problems, they are not present in what's happening here.
Okay.
They think about, what is going to happen now?
Okay.
So they are in the future or in the past.
Okay.
So mindfulness is a method where you learn to be present in your body now and not being judging it, but just being there, feeling what's happening.
Okay.
And that's something very promising, because that is also what sex is about, not worrying about how is it going to be in 5 minutes, but just being present and enjoying what you're doing now. So that's a very new shift in one of the treatments for women.
Now, coming to a little bit of sensitive stuff, but hypersexuality.
Yeah.
In men, it is lauded as being a playboy, but when it comes to women, they target them as nymphomaniacs.
Yeah.
It is very very bad.
Yeah.
So, what is to say on that? How to shift the focus from that?
I think it's a cultural thing. I think I think it's in most cultures we are a little bit afraid of women that are too sexually active, and I think it's a stereotype that women are not that sexually active. So if you have a woman that is sexually active and enjoys sex and says she likes it, you give her a tag, because it's a little bit scary, because in cultures we don't want women to be like that. So I think the way to change it is that we start recognizing that some women also like sex and they also would like to have sex. And she doesn't have to be hypersexual to get the tag. I mean, a sexually active woman is and have always been seen different than a sexually active man. And I think that goes in all cultures. That goes in Denmark and in India, that we have more freedom for men to be sexually active. So we expect them to be, but we don't expect women to be.
Yeah.
And that's why we have a certain name for women that like to have sex.
So how will you how will you differentiate good sexual activity, which is hypersexuality, in both men and women?
I think that the differentiation is that it starts having a very negative impact on your life. I mean, being hypersexual, you cannot think about anything else. It will have an impact on your social life, on your relationship, on your work life sometimes. Maybe you use all your money. So I think, and it's so distressful, it's almost obsessive. So I think that's the difference, that being sexually active but being able to control it is something different from having something you cannot control and that occupies your mind most of the time.
So can we see hypersexuality in future being classified under OCD?
I think the way it is now in the ICD-11, they have put much more focus on this maybe being an obsessive compulsive.
So now shifting from the disorders of or the problems of women to men, you initially started your thesis on male erectile tissue.
Yeah.
So tell something about male erectile dysfunction in men.
Yeah.
Something.
I think the story has been that about 30 years ago, we thought that all erectile problems in men were psychogenic. And then we got a lot of knowledge about how does the tissue in the penis work, what is happening when you have diabetes, when you have cardiovascular disease, what is happening with the tissue, and we recognize that a lot of the problems men have are due to organic factors, are due to changes in the tissue, changes in the endothelial cells, changes in the signal systems of the penile tissue. And that's where we had the PD5 inhibitors, because they work there. So I think one of the shifts have been that we now think more and more that erectile problems in men, especially older men, also have an organic cause. And I think that's one of the main things. The other thing is, I think it's interesting that we still have a lot of pressure on men that they need to be able to provide an erection.
All the time.
All the time.
Yeah.
Maybe even without desire.
Okay.
But that's the way we have masculinity.
Okay.
And I think a lot of, especially younger men, get more psychogenic erectile dysfunction because there's so much performance anxiety. They have to perform, and they expect it, and the woman expect it. So that's the way they have to show their masculinity. And then I think that we are very lucky that we have quite a lot of good treatment modalities. So we have pharmacological treatment that is very good, very safe. And we also can work with the more psychological aspects if you have someone that know how to do that. So I think that's, it has developed quite a lot, this area.
But still people are unsatisfied or dissatisfied because they are expecting a drug-free cure.
Yeah.
How far are we? Because when Viagra came in the market, and even now people think that it is a free, complete cure for them. Because people come to me, doctor, I have been taking Viagra, but still I'm not getting any cure.
Yeah.
So how to address the cure issue? Any focus on that? Can we expect
So you
something?
mean that even though they take Viagra, it doesn't work?
No, not only with the Viagra, but any way where we can achieve a drug-free cure for ED.
Yeah, I think that there has been a lot of talking about having gene therapy and other kinds of therapy. I know that some people are doing investigations in Botox.
Okay.
And I think that most people would like to have a drug-free cure, but it might be difficult.
Maybe in far future, maybe.
Because it has been there's been a lot of talk about it for quite a long time.
Okay.
But it's still not there.
Okay.
So maybe we need to wait a little bit more.
Because what we understand as practitioner, it is like an hypertension where you give medicine to lower the BP for lifelong.
Yeah.
So there is a hypertension in the pineal tissues. So we give drugs to lower the BP, lower the pressure in the pineal tissues. So there has to be some kind of a lifelong therapy.
Yeah.
Plus lifestyle modifications.
Yeah.
So people need to understand that.
I think that lifestyle modifications that's one of the good things, because there are some investigations showing that if you start exercising, if you have a healthier diet, if you don't have a sedentary lifestyle, it might help on your erection.
Okay.
So I think that would be a drug-free cure.
Drug-free cure.
But as a physician, you know how difficult that is.
Very difficult,
It's very difficult to get people to change their life, stop smoking.
Yeah.
But maybe you can do it here because men are very concerned about their erection. So I think that's always
But still,
very
it's a big challenge.
Yeah, it's a big
because they're
challenge.
very easy for popping the pills rather than sitting and having a mindful practice of changing their own lifestyle.
Yeah, so it's very difficult to change your lifestyle.
Then talking about this premature ejaculation, there are two types. So how to approach them?
Premature ejaculation is, I think, sometimes difficult to treat. We have the primary one where you have always had very rapid ejaculation, and then we have the secondary one where it used to be okay, and then you have suddenly premature ejaculation. The last one is often correlated to having erectile dysfunction too, because the man is so concerned about not keeping his erection, and then he ejaculates very early. But the primary one, there are two ways. You can either try to treat with medication, where you use SSRIs that inhibits orgasm, so you use like the adverse event. And for some men that works. The problem is that you have to take them every day.
Yeah.
And that's...
For how long?
As long as you have the problem.
There is no drug-free cure for this lifelong
No, I mean, some men will relax a little bit more, and then you can take them on demand, but some men need to take them every day. And that's quite a lot to go and take a drug every day because you have premature ejaculation. Then we have the more behavioral treatment, which is called squeeze technique, start-stop technique, which is a technique where you learn the man how to stimulate himself and stop the ejaculation.
While not having sex.
Not having sex.
Okay.
And making him able to control the ejaculation, because one problem is the time, that it goes very quickly. The other one is that the man has the feeling he cannot control the ejaculation. So you learn him how to control the ejaculation by stimulating himself and then squeezing under the glands, and that will stop the ejaculation. That can be very difficult if you live in a culture where people are not allowed to masturbate.
Okay.
Because then you tell them that they have to stimulate themselves.
Okay.
So you need to talk to them about this being something that the doctor actually tells you to do.
Okay.
You can also involve the partner, and she might be able to stimulate him in another way, or maybe other positions where he's more in control. So it sometimes takes a little bit time, but if the man works, he can learn how to keep his ejaculation back.
Normally, what mistake doctors do when they're telling you about this squeeze technique is that when you're having intercourse, you practice squeeze technique. But it is how, when they're not having intercourse, they have to get trained in this squeeze technique. That is the most important thing which they have to think about.
And sometimes you can, where I come from, we have like pictures we can show people to show them where to squeeze, where to press.
That's it. Okay.
Yeah.
Okay, that's good. And is there any some kind of an PE in men, I mean, like in women, where they tend to come orgasm very early?
Actually, that's a very interesting question, but it's an understudied area because we know that some women climax very early, but there are differences between men and women, and that makes it maybe not a problem if a woman climax very early, because the intercourse can still continue. The problem with men climaxing early is that
he can't do that
it
anymore.
stops. And so actually we don't have a lot of knowledge on women climaxing very early, but I'm sure they are there, but we don't know anything about it.
And even men should know about their own what can I say, the interval between the first like the ejaculation and the second one, their own refractive period. People just talk to friends, and their friends even they brag even falsely, I can go 4 times an hour. Then he tells, okay, I'm having an ED. Then they come to us. Actually, he must be a normal person. So men should be knowing about that.
I think that's very true, and I think there's a lot of bragging amongst men, and sometimes people come to me and say I have premature ejaculation and they can last for 10-15 minutes, and I would say no, that's not premature ejaculation, but they have seen pornography or spoken to someone and say that can last for 2 hours. And we need, that's what I call education. We need to educate people about, what is normal and what is not normal. Because
many men, like women, they learn about sex from pornography. So we need to have a shift from the learning. So that has to be addressed very early, but nobody knows how early it is. So it's still a big challenge in India. Sex education is still not happening. When you talk about sex education, even the parents they themselves they'll know it is not required now.
But I think it's a challenge in Denmark too.
Okay.
It's
still there.
Okay.
So is there any sex education classes going on for students?
I mean all schools have to give sexual education. But I'm not sure how much they talk about this. I think they talk more about how not to become pregnant, how do you have sex. It depends on the school and the program. But
and you have done multiple studies about sexual rehabilitation after a heart disease. So can you tell about your care model for managing ED in that?
I think that we did a very nice study where we introduced exercise and physiotherapy for men that had cardiac problems. So after they had their cardiac problems, they were randomized to either control group where you just gave them information about it's good to exercise, and then we had a more intensive treatment group where they got a trainer, they could go to a fitness center, and it actually showed that the men that exercised and the one that had more personalized training, they had a better erectile function. So this just tells us that it is good to exercise for your erectile function, but also that you need to support people, not just tell them to do it, as we discussed, that it's very difficult for people to do it. So they were very happy about also having a group where they could do it with someone they knew. So that's quite interesting.
So how to initiate this kind of group therapy in a very conservative country like India? Because once they have a heart attack, they themselves deem that I'm very old to have sex.
Yeah.
So I think we need to educate their own cardiac consultants, where they refer the patients to us, and we can address it very easily.
Yeah. I think the good thing about our study was that it was in the cardiac department, so they didn't need to be referred.
Okay.
The nurse that ran the study, she was there.
Okay.
And I think you're right that the other problem is that people that get heart attacks are older. And the physician will think, no, they don't have sex. They're too old to have sex. So we need to break down the understanding that old people don't have sex.
Okay.
And it's a problem especially for women with cardiac problems because they are older than men.
Okay.
And the physicians will think, no, she's too old, so we won't even talk to her. And we did a study where we interviewed people that had heart problems. And I think it was only 1/3 of them that had questions about their sexual life, even though we know that cardiac problems will give sexual problems. So we need to educate the healthcare providers that this is something that's important.
Just like I want to add a point here. I recently had a patient who had got renal transplant, graft failure, 43 years of age, young man. He's saying there, sir, I have to have sex till I die. But people argue that he's having renal failure, he's going to die. So why should he concentrate on having sex? Again, sex is becoming a big stigmata. Death is different, sex is different. He has to have a good quality of life.
And
so
I think for most people it's very important for your quality of life, and especially in men or women that are sick. I mean, it might add to feeling better, feeling more healthy, and not feeling sick all the time.
True. That is always.
You have more normal life.
So do you want to add anything about the care model for the management of ED?
I think that the care model for ED is very much about trying to get the whole picture when we talk about what's the problem. Try to address the more biological things. Be sure that the blood tests are okay, but also involving the more psychological aspects, so you have like a full picture of what is the problem, because there might both be some psychological aspects and some more organic aspects. Especially if you see men with heart problems, they might be very afraid of what's going to happen if I have sex. Am I going to die? And then you need to talk to them because they have anxiety. So you need to take care of all the aspects, and sometimes that can be very overwhelming as a physician because you think, am I able to do that?
Address all those things. One short question on that: can a cardiac patient have a missionary position sex? Is it safe for them?
I think it depends on the cardiac situation. If you have a stable heart and you are not just came out of the emergency room, there are some investigations showing that having sex is using about the same energy as walking to the 3rd floor or cleaning your house or doing your garden. So you need to find out if the person is able to do what you would call light housework or walking a certain distance without problems. If they can do that, they can have sex.
Because we advise women on top, but what happens women being obese after marriage or postmenopausal? It is very difficult for us to advise this position. So now it is a big challenge for us to address the cardiac patient's sex positions again. So you need, you need to think of how does the body react. So if you can feel you cannot breathe, you get chest pain, then it's too much. But I think you'll do the screening as you do with all other physical activity with these patients. I actually go with even post-cardiac patients also. A small TMT, a routine TMT and echo to see the wall motion velocity. If it is good, then I advise them you can have sex at any position.
I think that's the right approach.
So, and one more very interesting question: how to approach gay men who is having ED, who complains of ED? Come to us.
I think it's basically you approach it the same way, because they have an erectile dysfunction. You need to treat that. But having said that, we also know that some gay men are more sexually active, and some gay men have more focus on penetration, and maybe it's a little bit more difficult to penetrate. So maybe they need a little harder erection. So I would say that you treat gay men as you treat other men. but you need to recognize they might be more sexually active and they might have to have a harder erection. So that can be a challenge once in a while.
What we face challenge here is that gay men who's not able to express their sexuality, they get married and they come to us, tell doctor, I need to have sex with my wife. Please cure the problem.
So that's, I wasn't thinking of that. That's a very special problem because then it's difficult to treat the erectile dysfunction because of course they have erectile dysfunction because they don't have desire for what they have at house. And I think it's a very, very difficult problem to treat. And I think you need to speak to them openly about, I can give you maybe a drug that can help your erection, but we cannot cure that you actually are married to a person you're not attracted to. That's a
he tells like it is
thing.
Disgusting for me to have wife with my partner.
And then of course you cannot have an erection. So you need to discuss that that's how it is like that. And that's sometimes as a physician you cannot change it. I mean that's the circumstance you cannot change. But you can talk about why it is like that.
This is kind of an offshoot because I recently saw in a series where the Master of Sex series in Amazon Prime, the Dean of University, who's a gay, supposedly gay over there, he used to have his own erection by seeing a men pornography and go and have sex with his wife. So I tell this story, they get quite comfortable, and but the problem is not solved. But still, they are very comfortable while having sex with them because.
So then they can do something because I think, as you say, the problem is not solved because the problem is another problem.
Yeah, a problem.
And you cannot solve that.
I can't solve that because they just want to have a baby so that they are very fine with their own society. Then they can be very promiscuous. That is very dangerous access. It's quite challenging also. And any sexual issues with a lesbian woman because I have to finish it with the gay and lesbian thing.
No, I don't think there are any special issues. There are some indications that it's easier for lesbian women to have orgasm because maybe they know where to stimulate. And also there are some indications that they have less sex because they don't have the same drive as men. So if you have two women together. But I think that we actually do not know a lot about lesbian women and sex. I think they have the same problems. But also they might have easier getting an orgasm because they know how to stimulate.
See, we are in the era where there is sexuality expression is being appreciated. But you have been shifted from that old era till now. I mean, 20 years back. How do you see the shift? Because those days, gay and lesbian were considered mental disorders. And now they're removing that.
I think that the shift is, and I'm happy about that we see gay and lesbian so as that is just something you're born with.
But then, how did you approach those patients then when they come to you as a patient?
I think you should approach them as human beings. Not being judging them, not being telling them something is wrong, but recognizing this is their sexual orientation and try to help them the best way in their life. And
reinforcement is much more happier.
And
easier.
Not judging them. I think that's good.
Now coming to your recent research, mindfulness, MISR. Please tell us about how mindfulness is evolving as a concept. How as a practitioner we can practice mindfulness from the versions.
I think that what we are doing is trying to implement mindfulness in the treatment of sexual problems. And the idea is that mindfulness is about being in the present moment, not judging what is happening. So you just experience what's happening in your body and you try to relax with that. And you also recognize that sometimes something happens in your body because you have some feelings that has an impact on your body. So mindfulness is about practicing just feeling your body, not judging it, just being there. And what we do is that we try to give people a program of mindfulness because when we then teach them to do sensate focus where they have to be intimate with their partner, we hope that if they're mindful it's easier to do sensate focus because they will not start thinking, oh, what's going to happen now? Do we need to have intercourse? Last time it wasn't good. So we hope that they will be more present in the moment.
Is mindfulness an individual practice or a couple practice?
You can do it individually, or you can do it as a couple.
Because sensate focus is a couple practice.
Sensate focus is a couple practice. I think if you do mindfulness together, you do it like individuals, but you can do it in the same room or in the same group. It's like doing yoga. Everyone practice their own, but you can do it together. So mindfulness is something that you do with yourself.
So can I tell like this for not oversimplified? Meditation plus sensate focus is equal to mindfulness, or is it beyond that?
I think that mindfulness is observing what's happening in your body. Meditation is a little bit different. Meditation is about getting all thoughts out of your head. So, but they have the same aspects.
That's what.
But mindfulness is more about just recognizing what's like. You can do a body scan, just finding out what's happening in my whole body, and that's also very good for sexuality because sometimes people only focus on the genitals. But like focusing on the whole body. Sensate focus is more like doing something that you touch the other's body. So that's. But you need to be mindful when you do it. Meaning that you just are putting your focus on what's happening here when I do it. Not thinking about a lot of other stuff.
So can we have a mindful sessions somewhere for like treatment of sexual difficulties? Kind of a group workshop, like we can have it as a group workshop.
We have a group where we have like 6 sessions where they are taught to be mindful. So they get like exercises of doing a body scan or doing a yoga exercise with focus on what's happening. So you can teach people in a group,
But in India, how can we group person with sexual difficulty? So we have to be an one-on-one. So how to address this issue? Because I want to know about that. Because what you're telling, like it's kind of a wellness spa concept. It's kind of thing like that. So how can you implement as a pure therapy for a real patient?
I think you can do it in your clinic.
Individually?
Or you could also do it in a group if people accept it. But because in our group they don't talk about the sexual problem, they just learn mindfulness.
So mindfulness is a concept where you're implementing in sexual difficulties. So how much successful percentage you're seeing in the shift implementing this mindfulness concept?
It's still in the beginning. It's very promising, but still we need to see how well it works, because I think there's some people that are not able to be mindful. So I think it also depends on the people. You need to find the right ones. Like with therapy, some people are able to do it and some people are not.
Is it only in your place, or is it practicing everywhere around?
It's there is a researcher and clinician from Canada, Laurie Brotto, and she really introduced it into sexual medicine, especially for women. And then we have taken it, and now it's like spreading a little bit. So I think it's something that's going to grow.
So it's like it's evolving then. One last question, because there was a standard of sexual practices. A standard practices in sexual medicine book, 2005-06. Then after that, nothing came out. So are we missing something, or is it still evolving, something like that? I
think that the International Society for Sexual Medicine actually in 2015 and 16 came out with some new consultation papers where they address different aspects of treatment of sexual problems. And we're working on new ones, but there also need to be something new that we can work on, and not just sending out the same things. There need to be something new. The International Society for the Study of Women's Sexual Health are publishing quite a lot of white papers on how to deal with women, especially with desire disorder. There's a new one on its way about testosterone treatment. So there are coming new guidelines and approaches being published.
So do you have any parting message for our viewers from ISSM, from your side?
I think that it's so important that you're interested in people's sexual life, because that's important for people. And I think you give a better treatment to your patients if you address their sexual life and maybe help them if they have any concerns about it.
So, thanks for your time. I hope you stay in India will be a very good thing.
I'm sure it will. Thank you.
Thank you.